So welcome. Thank you for coming down today.
Thanks for having me.
And I wasn't sure what we were going to talk about, but I know it's going to be interesting. And I know we're both going to learn something, and we're both going to share something. And we'll be better at handling whatever challenge we choose to tackle.
Right. So I think one of the things that we kind of ended up with in our last talk was not necessarily, I guess, the two-pronged thing of what you say and how you say it.
Absolutely.
Right.
Yeah. And when you read any interview textbook, some of them will use different terms, but for psychiatry, there's always the content, and then there's the process. There's what you ask and how you ask it. And then the other thing is, you may already know this, but for when there's diagnostic criteria, there's a list. So what are the diagnostic criteria for depression? Maybe there's poor sleep, or you're sleeping too much, you're depressed, you're not enjoying things. And so it's a list of symptoms, but it doesn't tell you what words to come out of your mouth. Right? And so there's what are the words that come out of your mouth, and that sort of overlaps nicely with how you ask it. So that's a great question and comment. We both know that you could say something that's 100% right, but if it doesn't land,
right, it can have the opposite.
Yeah, think about it. Think about when a family member called you on some truth that was really personal, or something that you didn't even know was personal. Then it rocks them.
And maybe even when you say it could be the other component of that too, because sometimes there's a right time to ask, and then other times you ask too much, and you kind of regressed a little bit from the progress that you made because you kind of bombarded the client or the patient.
Yeah, absolutely. And so in the book that we had last time that I showed Sean Shea, around the psychiatric interview.
Yes.
It covers all these different components, right? So it covers a little bit on how to set the frame.
Interview assessment, same thing?
Yeah.
Okay.
Yeah, they use a lot of terms that it can sometimes mean similar things, sometimes mean different things. And it get confusing for a lot of people, myself included. And if I'm confused, obviously the person who's listening is going to be confused as well. And so for the psychiatric process, you want to think about the frame that you're setting. And so last time we talked, we were thinking about all these sort of different examples, but the frame is, you meet the person, the space you're in, how you introduce yourself, all that kind of stuff. Fascinatingly, in some of these books, so there's another one, I think, the psychoanalytic formulation, that person always uses their first name to introduce myself. Hi, I'm Nancy. I'm Nancy McWilliams. I'm a therapist here, all that kind of stuff. Whereas in medicine, we usually use the doctor framework and the doctor language for it.
Yeah, interesting. There's such a different, as a connoisseur from time to time of medical services, there are so many different presentations, from the full white coat with the entourage of residents behind you, a physician model, to I think the last time I was in an ED, which wasn't that long ago with COVID, but I don't have it now, is the doctor actually sat cross-legged on the end of my bed and started to talk to me and says, "My name is Karen." I changed the name. It's not Karen.
That's very interesting.
Yeah, and it was. Now, was it because she knew I worked there? I don't know, but it was so familiar that in a way I felt I don't know. I felt like maybe it was a little too familiar. Maybe, for me, right? Everybody's different. Maybe somebody that would be very disarming for somebody. But her approach to the conversation, especially when she was, sharing, results of tests with me and whatnot, right? Was just, it was different. I don't know if I have a judgment yet for it, but it was a little.
Yeah, well, I think the world has changed dramatically, right? So in the 40s and 50s, what was it about? It was like the doctor who's the expert. The doctor knows, the doctor's had X number of years of training, they wear a light white lab coat, they're professional, they have a stethoscope, and you go to them saying that they're the expert and they're going to help me. And so in that context, you want that person who's the expert telling you stuff.
Yes.
Whereas now it's more about, you do your own research, try to sort of figure things out. You might know things the doctor doesn't know. Everything's available online, all that kind of stuff. And so the more modern approach is that the doctors try to be sort of at the same level. And the challenge is that there's certain people that want that expert doctor, and they just want to be told what to do, what the things are, all that stuff. And then there's other people that want that person they can collaborate with.
Yeah.
And then sometimes people think they want one, but they need the other, and then it ends up being chaos. I can think of so many times where people are like, "Doctor, tell me what to do," and I tell them what to do, and then they get upset with me that I told them what to do. And so I think this has also come up, I think, when we talk about do we identify as someone who's supporting harm reduction, or do we identify as someone who's supporting abstinence?
Yeah.
And the conclusion we came up with was that we always do harm reduction. Because if the person wants abstinence, they'll listen to you after you come in with harm reduction. They might make fun of the crack or the crystal meth pipes or whatever else you have with you.
Yes.
But they'll still have a conversation about abstinence. But if you come in from the abstinence lens,
Yeah.
they won't listen to you there as well.
Right.
And I would argue...
It's interesting. Yeah, I never thought of it that way. But yeah, that is the sort of safe way of going about it, right?
Yeah, and I'm not sure what the safe way is around this, because some people want that expert to tell them what to do, and some people want more of that collaborative approach. And I can't tell if it's my personality style that makes me collaborative, or the way that I was trained, or what the patient needs. But there are some patients that I can tell that they want an expert. And then I have to stand a little bit straighter.
Yeah.
I have to be very medical in how I say things. And it's hard to know what brings that out in me. Usually it's when I'm working with somebody who's very competent, very capable, and they want the best, right? And then I have to act like the best, right? But if it's somebody who, maybe they've been traumatized by the someone in their life, maybe they have difficulties with authority, maybe people in authority have taken advantage of them, then I definitely need to sort of balance that playing field or squash the hierarchy or the power differential in some way.
Yeah, so I think that's, I think that's key. Sometimes, first off, I just had to assume what this individual did.
You didn't know they were a doctor?
Well,
Hi, I'm Karen, and I'm sitting at the edge of your bed. I got a sweater on. Hey, what's up? How you doing?
Yeah, right?
Yeah.
So I don't know, right? And I'm fairly good at navigating the system. In fact, I know many of the people. I didn't know her personally, but I knew the nurse. I knew the admin. I knew everybody in that little department that time. So it was an interesting thing. So if I was confused, I pretty well, by process of elimination, I figured out who she was, because a nurse certainly wouldn't sit on my bed.
Yeah.
That wouldn't
Fair
be.
enough.
So it's not a criticism, just an observation of the different styles that people have, and and you're right, and sometimes you get too familiar, perhaps. I don't think it's any different for a physician than it is for a caseworker. It's all about the approach and building rapport. Right? This is all about building rapport and building engagement. And for a lot of the patients that we support, it's really about getting them to stay engaged in the care, right? Because we know when they go out against the prevailing medical philosophy of what works for people, they come back much sicker, or they don't come back at all.
Yeah.
And that's the scary part for the population we serve, or at least it's the scary part for me as a provider of care.
In fact, that fear sometimes makes people take on more of that authoritative doctor role. You're going to die if you leave. You're going to die. You need this treatment. Da 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 da. And in fact, those people would need extra support in terms of balancing it out. It's one of those things where some of the stuff is some of the stuff you can figure out as you go. I do think there is value in following the standard approach, because then the person knows what to expect, you know how to be, all of that kind of stuff. It allows a less wiggle room for error, right? And so, for example, if I was sitting at the edge of the bed, I went by my first name, I sort of had a dialogue, people might not know I'm a psychiatrist, and I might get along so well with the person that I might not do a proper risk assessment, around suicidality or safety or all that kind of stuff that I'm supposed to do. And so for myself, I find if I have that structure, but the process stuff about how I ask is sort of sprinkled in, I can make sure the person knows that I see their value, I see them as a human being, that I genuinely care about them within that professional context. I can also create a space where they can talk and maybe share personal things they might not be able to want to share otherwise. And I can also give them information in a way where they're sort of in the driver's seat, where if they want direct suggestions, I'll give direct suggestions.
Yeah.
But if they're anti something and pro something else, I'll make sure they know the information, but I'll focus on the stuff that relates to them.
Yeah, it's an interesting discussion. I mean, as you know, I don't think I've told this story before, but you know, one of our colleagues that I used to travel around see patients with, a physician colleague in the hospital, where he would traditionally not, and I tend to dress nicer than I'm dressing now, but a little bit, you know, more professional, or I think professional, and this physician dresses a little less professional.
Are you talking about me?
No, I'm not talking about you.
Okay, just checking. Because I dress very casual, and I don't know if it's with intention or not, but that's fine. Okay, so
but
you're with this, you dress more professional. And
right, and so, you know, we would have conversations on the floors with different, you know, we're a consulting service, so we're not in charge of anything really, but we're giving orders and suggestions to people. And it's on more than one occasion, they have asked me if I concur with an order that the physician provided. And that was because I think the inference, probably because I'm an older person and then this doctor, and I'm sure that's the reason. But
I mean, the same thing happened with us a couple of times too, I think, right? And part of it is that, like, so for example, when I was a first-year resident, I was working with a phenomenal psychiatrist, Dr. Abby, who's a CL psychiatrist. So they see people who are admitted to hospital in that context. And she always used to wear a white lab coat.
Yeah.
And the reason she did that was because then the medical teams know that she's a doctor, the surgeons know she's a doctor, the ICU people know she's a doctor, and then when she talks to Dr. Lingo, it's not a surprise. But in the outpatient practice, her lab coat is off, she's in regular clothes, all that kind of stuff. And I think like it all depends on who your target is in some way. And it sounds like in that situation, they wanted a doctor's opinion. Right.
So if the doctors are confused, can you imagine how the patients are? Right? If the doctor on service wasn't sure who the doctor was, then the patient, because again in this particular case, the physician was his style was not to introduce himself as a physician. He introduced himself by his first name, right? Which is his approach, and I'm sure he's developed it over a number of years, and it's very well received, and he's good at what he does. Yeah. But if the doctors are confused, and maybe the patients are confused, and
sorry, I should probably let you finish. You know, I just a point keeps coming to mind when you're saying this. People that are going to want an expert medical opinion are going to do detective work to figure out what's this person's level of competence.
Yeah,
I suspect. So I imagine, say, if I was Karen or the doctor that came, I sat at the edge of the table, you'd probably ask me a few questions about myself. Oh, where did you go to school? When did you graduate? Just to try to figure out whether or not I'm competent. But if you were someone who'd been harmed by the medical profession, you know, maybe someone did a surgery you might not have needed to, they offered you treatment where you had bad side effects for it. Maybe it's something where the first name is a gateway for a conversation. Yeah. And then by you seeing the person as a human who genuinely cares, maybe you can talk about some of that stuff. I mean, who am I to say what's the right or wrong approach? But I think there's pros and cons to both. And I know colleagues of mine that would always wear suits or things to work. And in some situations it was very, very effective. And for me, I tended to always sort of do this. Although sometimes when I haven't shaved like this, people will make jokes on which side of the desk are you supposed to be on. You know, are you the patient or are you the doctor, right?
Well, there you go. So back to the message of what you say and how you say it. I mean, this is kind of how you look or how you talk, but also, you know, I mean, it's, you know, we talk about, you know, what messaging to give, and where we're not trying to be, you know, prescriptive or trying to direct, you know, or authoritative in telling a patient what to do, right? Because we know it doesn't work. Yeah.
Well, one thing that a friend texted me, because I've got this interview coming up, and I was like, well, how should I dress? Should I dress like I normally do at work or whatever? And his response was just, oh, match the moment. And I never thought of things that way, right? And when I think of things that way, I think about, like, you know, I probably wouldn't dress how I dress. You know, I'd probably
match the moment. I would think it would be too late by the time you got to the moment. Oh, damn! I should have wore this, right?
Yeah. Well, you usually have some idea what's going to happen in your day.
Oh, you mean like predict what the moment will be and dress to that?
Yeah, dress for the day.
That's like, a little bit like dress for the job you want, not the one you have.
No, but it's also dressing for the one you have. because you're dressing for that moment, right? That you're at
True,
that job,
I guess,
or
yes,
any
yes.
moment, dressing for the podcast, dressing for like a date, dressing for like a bedtime, dressing for whatever it might be.
All right.
So you can really apply it for everything. But I think like just matching the moment, I think is incredibly important. And then it also allows that flexibility to be a bit more personal if that's what the person needs. It allows you to be more formal if that's what the person needs. And there's some sort of wiggle room there as well. So for me, when I think about the process, and a big part of this is just being indoctrinated in the spirit of motivational interviewing, right? So for me, it really, I have those key headings I go through, but it's very patient-centered. I try to validate, affirm things, all that kind of stuff. People that are a bit more structured than I am, and you'll see it if you look at sort of the exam key, it's very rigid around, these are the things you have to ask, and, you know, did you do it in an empathic way? Did you do this? Did you do that? And I can almost imagine, you know, like just having catchphrases to start, which is sort of what I did. Oh, that must have been hard for you, or what was that like, or how's that going for you? Like having these questions sort of allow for that. So when you're doing the interview, usually what I like to do, depending on the person and the context, is if there's things that I believe are impressive or that I admire or that I'm curious about, I make sure the person knows that. Because usually when someone comes in to see a psychiatrist, usually it's all the deficits they hear. So if they have an interesting job or their relationship, I might say, oh, you really care about your family, you really care about this, or this is really important to you. I always give them a chunk of time to speak in the beginning because it's so important that people feel heard. And then the other thing that I do is I sometimes summarize back what I hear just to make sure we're both on the same page. And for when I was training to do exams, it was also helpful because the patient believed that I'd heard what they said. I could confirm or contrast whatever I said because they'd correct me if I was wrong. And then if I had an examiner, they would also know that I understood sort of what was going on. And I think, you know, over time you figure out the right balance of open versus closed-ended questions. Once you have that relationship, you can hyper-focus in certain contexts. And then when you're giving feedback and advice, there's a few strategies on how to do it in a patient-centered way, right? And so it's not what you say, but it's how you say it. Because if you just go question, 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 yes, no, yes, no, yes, no, yes, no, eventually the person's going to shut down and not give you the answers that are true because they just want the interview to end as quickly as possible.
Right, and this is part of that, you know, kind of the talk we've had a few talks on, which is like when is the best time to get all this information, and you know, some clinicians think it shouldn't all be in that first overwhelming session, perhaps, right?
Yeah, well, I mean, I think that's where the context matters, right? Is it a drop-in clinic?
Yeah,
is it a scheduled appointment?
Is it bedside?
Well, yeah, bedside. How busy is your clinic that day? How much time do you have without damaging other things? And
is there a screaming kid beside them, you know, trying to, you know, stressing the moment out?
And is there some urgent thing you have to sort out?
Right.
Because I usually try to sort out the urgent thing, and I also try to get them to come back. That's the stand. Like if I can do those two things,
right,
I'm in a good place, right?
Right.
From someone who uses working with people who use drugs.
Yeah, and I tend to have it when I'm meeting people for the first time. I tend just to kind of focus on that engagement part, right? Because I tend always to try to just and as I, you know, kind of sometimes the engagement, it's so tiny, right? It's just to keep them going. Maybe it's just you know, 1 minute in a hallway, right, passing by, trying to get them to come back.
Yeah, I mean, I think those micro interactions are essential, you know. And I think back to when I started at St. Mike's, our friend Tim, he'd always, anyone he saw, hi, how are you? He knew their name, people that were at groups, people that otherwise, and he'd always stop for that extra 5 or 10 seconds. It would take us like 10 minutes to get down the hall. But the whole point was, you know, I just noticed that he was able to keep people in the groups when he was involved. And I'm convinced it's those micro interactions before, the storytelling during, the micro interactions after. When people wouldn't show up, he'd sometimes give them a phone call right away. Hey, what happened? Where are you? You know, we're worried about you. Can you come in? Audio, and then have a screen flashing saying announcement overhead. We
could, yeah. Sounds like a lot of work.
Okay. Splice it.
Maybe a special animation that just says we're having an announcement right now and we're in the middle of a hospital.
Well, I was trying to figure out how to do, what do you call, confetti.
Confetti.
Because my wife, my mom was putting together a video for Uncle's birthday.
That sounded Freudian a little bit?
Yeah, a little bit, unfortunately. I mean, I admire both of them as people. So
but they are different.
They're different. I'm like that with the kids, too. I always say the wrong name, but that's fine.
Not quite the same.
So
where were we?
It's not what you say, it's how you say it.
Yeah.
And so we talked about a little bit about the basic structure. We talked a bit about how different people might respond to different things, and I mentioned a couple of sort of snippets about stuff that I do, and then there's also things that you would do depending on the condition the person has. So I mentioned around if they want someone who's like shows their competence versus someone who's more personable. You know, in fact, one of the medical school interviews they gave me when I walked in was like, do you want your doctor who's super skilled medically, or do you want one who's very personable? Right, that's what they say, right? And I mean, I don't know what the real answer is. I would say, well, you know, both, right? I'd absolutely want someone who's both. But if not, it would depend on who it was, right? So I mentioned, you know, for my mom, I would want someone who's very personable and friendly and pleasant. And you know, for me, I'd prefer somebody who just told me how it is. But then I said, you know, but if it's like a surgeon, then maybe I'd have the best surgeon, and then I would be the one who makes it personable for my mom. That's what I said. I think this is like, I don't know if it's like 20 years ago. I don't know how long ago it was. A long time ago. And so, but there's different strategies you can use depending on if the person's depressed or if they're hypomanic or if they're psychotic, all that kind of stuff. For example, people that have psychosis, they teach us try not to make eye contact, try not to do anything that makes sort of coincidences, things like that seem to occur. And then people who are depressed, you sometimes need to match a little bit. You can't be so high energy if they're depressed, but if they're manic, you can be high energy, and then you sort of slow them down. For personality symptoms or people with complex trauma, it's really important that they feel safe and accepted for how they are before you give that feedback. So, for example, there's this quote by Marsha Linehan that we'll probably get into when we do the DBT session. People with borderline personality disorder, and I think it applies to complex trauma too, are almost like that third-degree burn victim, where even the lightest touch causes immense suffering. And you can imagine, I mean, we know people, and sometimes ourselves, you know, someone says something, we take it very personally.
Yeah.
Like, oh, what'd you do over there? And you're like it's just like, are they like, it's just, the mind just keeps going.
Yes.
And so, you know, for our colleagues and friends that are very direct, saying this is how it is, this is what's happening, there's creative strategies on making it more personable to the person who's listening.
Right. And does this tie into that whole, like, you know, certain messages, as you know, we both teach a lot of healthcare providers about the work that we do, and then you know, we certainly get I know a question I got not that long ago was, you know, well, what happens? You got to tell somebody, you know, you got to tell them what they're doing is awful, right? Like,
yeah.
You know, and how to confront that, where it's like, you know.
Yeah. So my answer to that would be, you can tell them that it's awful. You have to make sure they trust you first. You have to make sure that they know you legitimately care about them as a person. You have to demonstrate it in some way.
Yes.
You have to show some kind of acceptance for how they are. And once you have that trust, it can be direct feedback. So for example, like one of my friends and colleagues who gives me very, very direct feedback, and sometimes it's hurtful, sometimes it's harsh, always inspires me to be better. The reason he can do that is...
It's not me.
No, you're more friendly and polite, which is good. I don't know.
Okay.
But
Just
my
checking.
point, yeah, because my point, yeah, we always assume it's relates to us. So both of us are like that. I was convinced that we were talking about the casually dressed person with you as me. So he can give direct feedback because I've known him for many years, and he's been there for me numerous times.
Right.
So he can go direct and give me feedback. My wife can now too, but when we started dating, I used to take stuff very personally.
Yes.
You know, and so it's just one of those things. So for that person that says, you gotta just let them know that they're gonna die. How do I tell them? How do you really get to them? They have to feel accepted first.
Yeah.
And if you can create that space of acceptance, you can create that safety, then you can give the feedback.
Yeah. Well, I mean, beyond kind of that, you know, which is a talk to itself, that, you know, kind of that whole, you know, end of life kind of conversation that needs to happen. But even before that, where it's like, I like to say to people, you know, I don't, you know, I'm not coming at this from a judgment perspective. I don't have a, you know, I have no position on, you know, on how you govern yourself from this point forward, and I'm not judging you. Like, I try to, like, kind of take that down. I'm not sure, I'm struggling with the words right now as to
No, I know exactly what you mean. Like, you're letting them know that whatever they do is their choice, and you're supportive of them no matter what.
Yeah.
And you're just there to have a dialogue and conversation.
Right.
And you do that every time you see them.
Right. And I'm trying to give you information about what's going to happen next here in this process, right? Even, and it's not necessarily from a medical perspective. I'm not giving medical information. I very rarely put in a place to do that, although sometimes I am. But it's just like, okay, you know what? I really don't care if you keep throwing these trays at the nurses. You can do it all you want. I get it, right? But I'm going to tell you what's going to happen next, right? So
well, that's interesting.
What's next is the security is going to come. They sent me in to try to diffuse the situation, and that's happened a number of times. But I will be the next persons that come in won't be friendly trying to approach you. They will be removing you out of here. So you do whatever you want to do, but I just want to give you that information and give you an opportunity to see how we can kind of see if we can find a solution to this.
Oh, great, good.
Right? I mean, that's my approach to that.
Oh, I like
right?
it.
But everyone's different. But it's just me saying, I don't care if you throw the trays.
Yeah, it's almost like I think one of the things that we do in medicine, or we do with family members, we do whatever, we're almost making a certain kind of acceptance conditional on them making a choice. Right? Where if they do a certain choice, we'll accept them. If they don't do a certain choice, if you take your antibiotics, we'll accept you. If you don't take them, you're leaving. And what you're doing is that you're keeping them that choice. So it's really an MI thing around autonomy. And then you're like, the other thing that you're doing, which is very creative, is that whatever the problem is, instead of the problem being between you, is you're both looking at it.
Yes.
Right? And so you're actually beside them looking at it. And I think that's a very creative approach. I know a lot of people that use those indirect techniques to try to, because once you're on somebody's side,
yeah.
I think when you do couples counseling, well, that's what you do. You get them to both at the same side looking at the problem instead of seeing that problem in each other.
Yeah.
And in that, you pretty much disarm the person when technically you are on their side, because you don't want them to get kicked out, right?
Yeah,
but if they want to get kicked out, you're not going to.
I don't think I've met anyone that has thrown a tray at a hotel at a hospital staff member that's been treated well by the system.
Yeah.
Right? And I get it, right? I get it. And you could be talking about, so many different factors that have led to that. It's not just because, they didn't like the cornbread, right? There's reasons behind this.
Of course,
right?
of course.
And
and then there's past traumas, there's intergenerational stuff, there's being treated unfairly. I mean, you'll hear a lot of examples and stories around those things. Yeah. I'm just looking away because I'm just trying to think about how to sort of summarize this, right? Because I think there's so much here in terms of it's not what you say, it's how you say it. And then there's so many different contexts that this could apply to, right? And it's really the holy grail that you're talking about, like how do you make your message effective?
Right, yeah. How do you make your message effective?
Yeah.
So how do you make your message effective?
What we just talked about was how do you gather information in a way that's effective?
Yeah.
Right, and I think the way that I think about it is that if the person wants the advice, so for example, say you're asking me for something, right? Yeah. How do you get such good hair, right? How do you brush it and all that stuff? Then I would give you that direct answer about how to do it. But say I saw your hair and I'm like, I don't like it, I want his to look like mine. I would be very indirect in how I do it. So I might use storytelling, I might give you an example, I might say, oh, somebody else, I got through it like this. And so depending on how connected you are with the person and how much they want that feedback, that's how direct or indirect you go. Yeah, so it all depends on the state of the person, right? And so the more that they're receptive to you, the more direct you go when you say, these are the steps you have to do.
So if you've built that, once you kind of gauge where you've got, if you built a little bit of rapport or enough rapport that, the walls are not this high.
But even if you haven't built the rapport, but they're like, guys like, Doc, what do I do? My legs are swollen, right?
Yeah.
What do I do? Then I can say, look, your legs are swollen because you're retaining fluid. These are the meds. These are the diet changes you make. Let's get to it. How can I help you so we get those done? Right? But if the person has no interest in hearing it, the way to give the message the way the person hears it is just be more and more indirect. So you can get stories, you can say, well, sometimes we have people come in where their legs are swollen, sometimes this and this work, sometimes those other things help people, so it's more sort of indirect. And there's all these creative ways to be indirect, and the indirect ways, you'll see them in sales, you'll see them in education, you see them in effective presentations, you see them in movies. Sometimes they'll have messages embedded in movies that are done in an indirect way. And so it's almost like when the person wants the message, be direct, right? So like, I broke my ankle, how do I have it heal? Be direct. And for us, you know, when we're educating, like, so if we have people that come in that are ready to learn about addiction, we can be very direct in what we're saying. This is what you do, this is how you do it. But we have people that maybe don't necessarily want to learn about it. They're so busy with their other stuff, they'd rather refer somebody somewhere else. That's when we have to be indirect in the...
So an indirect way would be maybe bringing up another hypothetical, you know, imaginary patient and had a journey with, and just leaving that as a story, right? So we had,
that's exactly.
Yeah, we had
Exactly.
You know, we had a gentleman here a couple weeks ago that had this. He took these meds, and you know, it worked out well for him. And then keep talking about something else, or keep talking about what they're talking about, but you've not said anything direct, but you've planted that seed and see where it goes.
Yeah, the idea stays there. You know, I think like at the very least, you know, even I find some people that aren't comfortable going out of their previous practice, they'll at least know that other people sometimes approach the situation in other ways.
I like that.
Yeah, this whole direct indirect thing I think is a phenomenal
I like that,
area.
Yeah.
And I think there's a lot of overlap in other fields that aren't about direct medical care.
So it's kind of testing the waters a little bit, is it? A little, you know, with an indirect message and seeing if there's if that indirect story, the example I gave about the other patient, if the patient nibbles on that and says, oh, well, how did it work for him, or could that work for me?
I mean, I struggle so much with generalizations. I have to think about the context. Yeah, of course you do. But I think about the context.
Right,
I think
of course.
If the context is that, like, say I'm a consultant and there's an MRP, and the person needs methadone, but nobody in the hospital's ever done methadone,
right.
I might start with indirect, and then eventually it might have to be direct, you know, because of, like, you can't just be indirect when it's a life and death situation.
I understand, but just you and the patient, leaving all those other things aside, I mean, that's the indirect approach.
Yeah, I'm very indirect, especially if they've already heard it. So if the patient's already heard that they might die of this, might die of this overdose, or this, they say I'm leaving anyways, then I give the indirect messaging.
Okay.
And the best way to come up with these indirect messaging is, so say if you ever go to a teaching session and there's someone that's worked in a clinic for like 5, 10, 15, 20 years, you don't ask them what they do, you ask them how do you do it? How do you give the message? And when they tell you the stories that they tell, they're giving all these gold nuggets. So some of the greatest things that I've kept in my own practice of speaking to patients is stuff when I've seen a colleague who's very good at it, or they've been doing it for a while, I'll say, how do you convince patients? How do you win someone over? Just like, remember we did that talk on ethics, and the one guy was like, but how did you win over this conservative family and get them all these harm reduction supplies, right? And it's not what, it's how. And the same thing comes in here. It's not always what, it's how. Anybody can memorize what.
Yeah.
Anybody can have a list and go through it and go through all that stuff.
Absolutely.
But that how part they can.
That's the tricky part.
Well, that's the magic.
That's the magic.
Right. That's the magic,
Yeah.
and that's the magic we're trying to get better at.
Yes.
And that's why we have this channel, so the audience can get better at it.
Absolutely. Okay. Well, that seems like a good point to wrap it up.
Yes. Thank you.
Okay. Thank you.